speaking of GI tumors, one drug we haven't talked a lot about is Aflibercept. Could you give us the perspective from the GI world about the role this agent plays?
Sure. So Aflibercept is also known as VEGF trap. It's a combination antibody of VEGFR1 and VEGFR2, and it's a very novel idea and a great sort of scientific discovery that you can, sort of combine two receptors to create a drug to try to inhibit the pathway that these receptors would belong to. And it has activity, as was mentioned in the Valor study. In the second-line setting, it does improve chemotherapy versus chemotherapy alone in colon cancer. I think that one of the challenges with the drug is the increased toxicity. It not only inhibits VEGF-A and VEGF-B activity, but also placental growth factor. And that actually, there's data that suggests that actually may augment the diarrhea that's seen with Aflibercept. So, the challenge with that drug is that although it is an anti-angiogenic agent, it isn't similar to ramucirumab or bevacizumab in the fact that the toxicity spectrum is probably more so. And when you add it with chemotherapy, it magnifies the problem. So I think for those reasons, it probably isn't most commonly used as an anti-angiogenic drug in colon cancer.
So I was going to say, you have a plethora of anti-angiogenic agents in colon cancer. And in the case of Aflibercept, does that toxicity disadvantage with an active drug, does it make you want to use it earlier in the course because you can use these others later when toxicity may be more of an issue, or is that really not even a thought process?
So it was looked at in the first-line setting in a randomized phase 2 study. So it was Folfox plus Aflibercept versus Folfox alone, and that study didn't really show us a benefit to using Aflibercept there. Especially when you think about colon cancer, the first-line patients are going to be on that regimen for 10 months to a year. And so we've started to modify these regimens for colon cancer patients more to ameliorate toxicity than to do the toxicity up front when they're still healthier. So that's the trend that's been happening in colon cancer. I think what happened with Aflibercept is when you have 3 different agents now that all show similar efficacy, then the question becomes, what's the toxicity and what's the wallet toxicity? And certainly we're in New York, and there was a lot of discussion about cost, right, and cost control. And I think and this is just my own take at market usage and what I see patients coming in with, is that in the second line setting, people tend to just stick with the bevacizumab because it's what they've done. It's been around the longest. Occasionally, you'll see a ramucirumab patient or an Aflibercept patient. For Aflibercept, there's one niche population where it seems to be used a little bit more, and I think reasonably so, is in a patient with a KRAS mutated colorectal cancer who has very rapid progression in the first line, and you want to give them something in the second line. Folks have used Aflibercept there to say, well, do they need something a little bit more anti-angiogenesis? Now, nobody's proven that, but that's probably the niche population where you'll see that used.
Does there seem to be more activity in that population, or
not necessarily?
Hard to
I think this is more of a let's try to use something different.
Right.
And that population has never been studied specifically there.
And of course, in lung cancer, Aflibercept had a negative trial and really never got any traction.
Not at all. We're very excited about the fact that we can measure, but not much at all, unfortunately.